Okay, today we're going to talk about the second part of anemia. So hopefully you've already watched the first lecture that talks about iron deficiency anemia, B12 anemia, pernicious anemia. What else did we talk about? Folate deficiency. So make sure you watch that video first, and then today we're going to talk about the other anemias, as I call them. So we're going to start first with thalassemia, and some of these there's some words in here that are even hard for me to pronounce. So as a family nurse practitioner or an adult gero primary care nurse practitioner, you're going to have to know these different types of anemias, not only for your certification, but you need to know them in practice in case you see patients that have symptoms. So if you look at the normal red blood cell here on your left, you can see they're round, and the ones on your right, which is thalassemia, they're not round, so it's harder for oxygen to attach to them. So you can see they're misshapen. So let's talk a little bit about thalassemia. So your hemoglobin is made up of two proteins, the alpha globin and the beta globin, just like, or I should say globin, alpha globin and beta globin, sorry. And thalassemia occurs when there's a defect in a gene that helps control the production of one of these two proteins, either the alpha or the beta. So there are different types of thalassemia. There's alpha thalassemia and there's beta thalassemia. So it most often occurs in people of different descents or different ancestry. So you can see here that alpha occurs mostly in people from Southeast Asia, the Middle East, China, and those of African descent. And in the beta ones, it's similar, but it's mostly people of Mediterranean origin, and sometimes Chinese, other Asians, and African Americans can be affected. So it has to do with something to do with genes and mutations they're missing, or something's happened to that gene that you need to make those proteins. So there are many forms of thalassemia. There's thalassemia major and thalassemia minor. So thalassemia major, you have to inherit the gene defect from both your parents, and in thalassemia minor, you just need to get it from one of your parents. So some of the symptoms, so for the most severe form of alpha thalassemia, you'll see stillbirth in women, and then children born with beta thalassemia major, which is also called Cooley anemia. You might hear being called that in the hospital. They're normal at birth, but they develop severe anemia during the first year of life. So you need to know this, because if you see a patient that's 6 months old, say you're doing family practice, you see a patient 6 months old that's exhibiting some of the symptoms, then that's what they need to be tested for. So other symptoms can include bone deformities in the face, fatigue, growth failure. So the red blood cells carry nutrients. So if there's a lack of that, if there's issues with the red blood cells and they're not getting as much nutrients, shortness of breath because they're not able to carry oxygen on their red blood cells as well, yellow skin, and sometimes people with minor forms of alpha and beta thalassemia, they might have the small red blood cells, but they don't have any symptoms, and then dark urine. So some of the testing you might want to do is a CBC, and the CBC is going to show that the cells are small, and if they look under the microscope, they're going to see that they're shaped abnormally, like you saw on that first slide. And then there's a test called a hemoglobin electrophoresis, and then a mutational analysis test that can be done also. So the treatment for thalassemia major usually involves regular blood transfusions and folate supplements. And then if your patient is getting a lot of blood transfusions, make sure they're not taking iron supplements, because people who receive a lot of blood transfusions usually need chelation therapy to remove the excess iron from their body. And then a bone marrow transplant may help treat the disease in some people, especially children under the age of 16. The prognosis isn't good if you have severe thalassemia, because your average lifespan is between 20 and 30 due to heart failure. But if you get regular blood transfusions and chelation therapy, then you might have a better outcome. You might live longer. Less severe forms of thalassemia usually do not shorten your lifespan, And then if you have a female patient or a male patient that has a family history of thalassemia, you might want to send them for genetic counseling before they get married and have children. So sickle cell anemia is what we're going to talk about next. And I am in no way an expert on any of these anemias. I just know a little bit about them, just enough to know that if I need to test for them or I need to refer them to hematology. So that's the thing about family practice, is you got to know a little bit about a lot. So sickle cell anemia, you can see here it was named after the sickle. This is a sickle for cutting grass, and you'll see the shape of the blood vessels. The red blood cells are also sickle shaped. So the problem with that, they're not only sickle shaped, but they're rigid, and so they get stuck right here in all the little capillaries and arteries, causing a backup of blood, almost like a blood clot, giving people pain with sickle cell. Especially when they get dehydrated, it gets even worse, like in hot weather, or if they're sick and they're not drinking a lot of fluids. So it's an inherited hemolytic anemia, and we're going to talk a little bit about other hemolytic anemias a little bit later. And if a baby is born with sickle cell anemia, both parents must carry the gene. I'm going to show you a picture of that. In the United States, it mostly affects African American people. I know when I go to Kenya and Tanzania, we see kids with sickle cell, and their average lifespan there is 12 years old, because they don't have the treatments here. So here's how the gene is carried. So if you have 4 children, 1 child will be affected, 2 will be a carrier, and 1's going to be unaffected. You're going to hope that you're the unaffected child. Symptoms. So you'll have anemia because sickle cells break down easily and they die quickly. So the normal red blood cell lives about 120 days, but with sickle cell, they usually die in 10 to 20 days, so that leaves you with a shortage of red blood cells. So your body's making them all the time and replacing them about every 120 days. But if some of them are dying every 10 to 20 days, then you're going to be quite anemic. Sickle cell patients get episodes of pain. They get painful swelling of hands and feet. We talked about the reason being that those sickled cells seem to plug up the arteries. Sometimes they'll get frequent infections because they can have damage to their spleen, which helps them fight off infections. Also, they could have delayed growth because we talked about how your red blood cells carry nutrients. And then vision problems, because the tiny blood vessels in your eyes can become plugged with the sickle cells, and then it'll damage your retina. Treatment usually involves, well, there are some treatments. Usually what I notice, at least in family practice, we usually just try and avoid crisis, relieve symptoms, and prevent complications. But you can do bone marrow transplants, they're also known as stem cell transplants, and that offers the only potential cure for sickle cell anemia. And like I said earlier, it usually needs to be done before the age of 16. So medications. So some kids with sickle cell may be put on antibiotics from the age of 2 months until they're 5 years old, just to prevent them from getting sick so much. There's pain relieving medications, and those of you who have taken care of sickle cell patients, you know how painful sickle cell can be, especially at crisis. And then there's hydroxyurea, which they can take daily. There's not, from what I could tell, there weren't a ton of studies on this, but they have found out that it might work by stimulating production of fetal hemoglobin, which is a type of hemoglobin found in newborns that helps prevent the formation of sickle cells. So there's potential. And I have seen patients on this, sickle cell patients on this. Some of the complications, as you can imagine, are stroke, because the blood vessels get plugged up and then blood can't get through. Acute chest syndrome, they'll get chest pain, pulmonary hypertension, organ damage, blindness, leg ulcers, gallstones, and then men can get priapism, which is where they have an erection, painful erection lasting longer than 4 hours, and it can really actually damage their genital organs. So they definitely don't want that. So you could get a sickler that comes in with that. Okay, so there's a lot to learn about anemia. So let's talk about aplastic anemia, which maybe you've seen in the hospital. It's a blood disorder in which the body's bone marrow doesn't make enough new blood cells. So this can result in a bunch of health problems such as arrhythmias, enlarged heart, heart failure, infections, and bleeding. Aplastic anemia is rare but very serious, and it can happen suddenly or it can happen over time, but it usually gets worse as it goes on, so it needs to be found early and treated early. Some of the causes, almost half the people we don't know what causes it, but the other half, it could be from being exposed to toxins such as pesticides, arsenic, and benzene, which is why you really want to always get a family history, a social history on your patients. Make sure you know what they do for a living, what their hobbies are, because you can see how they could be exposed to some of these things. So pesticides, if maybe they're a gardener, and then radiation chemotherapy, so you're going to want to know their past medical history for that. Any medicines that they might be on. If they have an infectious disease such as hepatitis or a history of Epstein-Barr virus, cytomegalovirus, parvovirus, B19, and HIV. And then autoimmune disorders such as lupus or rheumatoid arthritis. And then these other inherited conditions that you can read on your own. Some of the signs and symptoms are similar to all of the other anemias. Fatigue, shortness of breath, dizziness, headaches, coldness in your hands and feet, I should say in their hands and feet, pale skin, gums, and nail beds. So you want to look at people's skin, you want to look at their gums, and you want to look at their nail beds, and also the palm of their hands, and the conjunctival sac. You can see if that's really pale. And they might have chest pains. The treatment for aplastic anemia includes, just like sickle cell, blood transfusions, and these can prevent or limit complications. They can relieve symptoms and improve quality of life. And in some cases, a cure can be possible, especially if it's caused by a toxin. If you can remove them from that toxin, make sure they're not exposed anymore, sometimes they can be cured. So now we're going to talk about hemolytic anemia. And we've already talked a little bit about it with sickle cell and thalassemias, but we'll talk, there's a couple more different types of hemolytic anemias. And if you do the broad sense of hemolytic anemia, it's a condition in which red blood cells are destroyed and removed from the bloodstream before their normal lifespan is up. Remember, we were talking about sickle cell, where the red blood cell lasts about 10 to 20 days. And there are many types of hemolytic anemia. Some of them are inherited and some are acquired. So I'm going to kind of show you a list of those. Some of them I can't even pronounce, so you can just look at some of them. But we already talked about the inherited ones. The sickle cell, at least in the thalassemias, not the other ones. And some of the other ones maybe you've heard of. And if it's inherited, obviously they have to get it from their parents. So their parents have to carry the gene, either one or both parents, depending on which type of hemolytic anemia it is. And then acquired is something that some disease condition or factor destroys the cells too early. So such as immune disorders, infections, and maybe a reaction to some medications or blood transfusions. So you can see on your left some of the different acquired hemolytic anemias. So some of the signs and symptoms, as you can guess, are very much similar to all the other anemias. Here you go. Shortness of breath, dizziness, fatigue, chest pain, leg ulcers, and a severe reaction to blood transfusion. Treatments, similar to all the other anemias too, blood transfusions. I'm talking about hemolytic anemias, not like your iron deficiency anemias. And then there are people that have mild cases of hemolytic anemia, and they may not need any treatment at all as long as it doesn't cause any symptoms. And these are some of the references that I used. So hopefully you learned a little bit about anemias, and you'll know a little bit more when you go to take your boards. And for the exam that we'll be giving you, there will be some questions that are from this lecture and from your readings. And in your readings, there's even more blood disorders that you're going to be reading about that I have not gone over today. So be sure and on your own, if you have some questions about some of these anemias, go ahead and look them up and do what you can on your own to learn about them.